Hello guys, so welcome to another video, and I am going to cover one more objective today regarding substance related and additive disorders from MCC for QE1 preparation. So I've covered three objectives so far in my videos. Previously I've covered hyperkalemia, hypokalemia and hyponatremia. This is the fourth objective that we're going to cover. So MCC objective has two different objectives for substance related disorders. One is substance withdrawal and the other one is substance use and additive disorder. So this is the one that we are covering today. Substance withdrawal is something that will be covered in emergency medicine. So let's start with substance related and additive disorder. So I would like to start with what components we're going to cover in today's video. We're going to cover substance related additive disorders including nicotine, alcohol, and nicotine will be covered in family medicine chapter, so not to worry about that today. And alcohol will be covered today, but some of the parts are there in family medicine, emergency medicine that we're going to do. Along with that, the major additive disorders that we need to really focus today on is opioids, very common in Canada, and then we'll cover on cocaine and amphetamine, cannabis, hallucinogens, and then in the last we have a very nice table in Toronto notes that we'll be covering today. Okay, so this is about it in the today's video. These are the components of the video today. So let's start. I'm gonna start with the objectives in MCCQE1 website. So I have the objectives with me. Let me see if I can open it for you in the in here as well. uh, MCC. If you open up MCC, you go to examinations and then you enter objectives, enter medical experts, and you will see. Let's get to S. In S, we have substance use here. So substance use and substance withdrawal, two objectives. So we're gonna do substance use today. Okay, so let's read this. Substance use disorder include addiction to substance such as stimulants, cocaine, amphetamine, that will be covered in Toronto notes today, depressants, opioid, benzodiazepines, and other substance, nicotine and alcohol. So this is very specific to Toronto notes. Nowhere else you need to look for the material. Additive disorders includes process behavioral addiction such as gambling. The neurobiological basis of addiction is similar for substance use disorder and additive disorders. Both disorders can cause direct and indirect harm to patients and families. Harm can occur during intoxication, withdrawal, and may adversely affect the individual's social functioning. There is frequent overlap between addictions and comorbidities are the rule rather than the exception. Physicians should be aware of the risk of addiction and adhere to the best practice when prescribing potentially habit-forming medication. So basically, what is the role of a physician in the entire substance use disorder is like patients are prescribed opioids, patients are prescribed amphetamines for certain disorders. So we prescribe amphetamines for ADHD, ADD, and then opioid is prescribed for pain disorders, chronic pain, PTSD. So these are the situation where physicians are prescribing medication and they should be aware of the risk. So that's the main crux of the objective. Okay, so the causal condition which may be the leading cause for prescribing these drugs is adverse childhood or traumatic experience. So patient may have adverse childhood. This is also known as ACE. ACE is adverse childhood experience. Epigenetic factors, comorbid illness like mental illness, chronic disease, trauma, acute and chronic pain, psychosocial stressors in employment, isolations, systemic racism, and other social determinants. So, the objectives given a patient with substance use disorder, the candidates will identify the issues, the potential consequence, and need for immediate intervention and ongoing support. Given a patient with chronic pain and other conditions who is at risk of substance use and additive disorders, the candidate will prescribe medication with due care. So, so let's see the objectives directly. Objective number one is list and interpret clinical findings, including the potential for habituations, and indicate the most appropriate medication for the diagnosis. So number one is the clinical findings and the potential for habituation. That is the previous history of substance use disorder in a person, a young patient with PTSD, a young patient with chronic pain. These are the potential risk for habituation and indicate the most appropriate medication for the diagnosis. So let's say a patient is in chronic pain, what medication you're gonna prescribe. So that's what you should know. And then construct a management plan, prescribing according to the evidence-based guideline, dosage, prescription, interval, monitoring the use of drug, and to minimize addiction. Initiate alternative therapies, taper stop therapy when there is an evidence of ineffectiveness and habituation, physiotherapy and psychotherapy. And now, how to help the patient once they are into the addiction. So these are one component of the objective, and then there is an appropriate history, collateral history, and relevant presenting problem. So by history, how do you know that a patient needs an opioid or is in substance overuse? And then through examination, how would you know? So for specific drugs, there are physical signs, let's say pinpoint pupil, tremor, sweating. These are the symptoms that we will get to know that this is a certain medication. So we'll look into it in a while. Then there is a critical investigations. What investigations you're gonna do? You're gonna do drug screen, urine drug screen, or what tests you're gonna do before prescribing or after a patient has been into the substance use disorder. And then behavioral modification, the options of appropriate pharmacological interventions like nicotine, opioid replacement therapies. So once the patient is into the substance use disorder, what replacement therapies you're going to give to the patient to help him come out of that use disorder, right? And then determine whether the patient or the family members require specialized psychological and supportive care, addiction treatment, psychosocial effects and safety, advocating safe injection, naloxone administration, education. So these are few um, objectives that we need to cover in today's video. Okay, so there's a long length of objectives today, so we'll try to cover the topic first on the from the Toronto notes, and then we're going to come back and revisit the objectives if we have covered entirely or no. Okay, so let's start here. So this is from psychiatry chapter, and this is one of the objectives that we're going to cover today. So let's start. Substance use disorder, a neurobiological disorder involving compulsive drug seeking and drug taking despite adverse consequence with loss of or control over the drug use. So what is substance use disorder? Where the person is drug seeking despite knowing the consequence of the drugs or adverse effect related to the drug, with loss of control over the drug use. Think the issues with the three C's. Remember these three C's: compulsive, consequence, and control. Okay, and it is possible to have the substance use disorder without physiological dependence, withdrawal syndrome, or tolerance. Dependence is a hallmark of substance use disorder and comes in the following form. So if you're considering a substance use disorder in a patient, make sure that patient has dependence, that is he's constantly seeking drug despite knowing the adverse outcome of the drug. Okay, so these are the following forms: behavioral, substance seeking activities, pathological use pattern, physical physiological withdrawal effects without use or tolerance, cognitive continuous or intermittent craving for the substance to avoid dysphoria or to attain the desired effect of the substance. So these are the three forms that comes with the these are the hallmark for substance use disorder: behavioral, physical, and cognitive. Well, now, what is drug misuse? Drugs use that deviates from the approved social and medical patterns, usually causing impaired or disruption of the function in self or others. Misuse is when a certain drug is prescribed, but it is used beyond a limit, and it is causing the disruption of the function in the body now, right? So let's say an opioid is prescribed to a patient for pain, but he's taking like 3 to 4 pills or going beyond that prescribed pattern, then that is the drug misuse. These disorders are usually chronic with relapsing and remitting course. There are 10 separate classes of substances identified in DSM-5. Alcohol, so there are 10 different substances, okay? Number one is alcohol, caffeine, cannabis, hallucinogens, PCP or similarly acting acryl cyclohexylamines and other hallucinogens, inhalants, opioids, sedatives, hypnotics, anxiolytics, alcohol included in that, stimulants like amphetamine type substance, cocaine and other stimulants, tobacco and other unknown substances. Whereas substance use disorder imply addiction to substances, addictive disorders including process behavioral addictions such as gambling. So this is an overview of the substance use disorder, where we should know this is a new neurobiological disorder, and there are dependence is a hallmark for substance use disorder. There are behavioral, physical, and cognitive forms of it, and then drug misuse is when certain drug is used beyond its prescription, and then there are 10 different types of classes of the drugs that can be misused, like alcohol, caffeine, etc. Okay, now now coming to epidemiology, not very important for QE1, but let's just rapidly go through it. Lifetime prevalence of SUD in Canada is 21.6 lifetime, and 10% of the last would 10% For the last 12 months. For alcohol use disorder, it is 18.1, 3.2, and for cannabis use disorder is 6.8 and 1.3. So they are comparing lifetime versus 12 months. And then for other substances, and for other substances, uh, 4 and 0.7 respectively, data before legislation um, of cannabis use in Canada. 47% of those with substance use disorder have mental health problems. So that means approximately 50% usually have mental health problems who are into substance use disorder. 29% of those with the mental health disorders have substance use disorder. 47% of those with schizophrenia and 25% of those with anxiety disorder have substance use disorder. So that's how it is. So 50% approximately in mental health disorder, they have also subclassified, like 50% would have schizophrenia, whereas 25% would have anxiety and substance use disorder. Okay, now etiology, the causes. Why would someone end up in, having substance use disorder? Almost all drugs activities related to dependence directly or indirectly increasing the dopamine release from the ventral tegmental neurons synapsing onto the nucleus accumbens, known as brain reward pathway, an action that contributes to the rewarding properties. With repeated use, they can modulate signaling pathways, which further encourages their use and contributing to their addictive potential. So what happens is, why is someone getting addictive, or is someone getting addiction of using a drug? It's because in the brain, when someone starts taking the drug, the dependent drug, there is a rewarding system in the brain that is stimulated, and that is particularly related to increase in the dopamine from the certain areas like nucleus accumbens, which causes the person to have the feeling of reward, happiness, the best feeling in the world, that the patient gets from taking the drug because of the increase in the dopamine from the certain areas of the brain. The reward pathway is activated. Now, this is one reason. The other reason is substance use disorder arises from multifactorial interactions between the genetic, individual, psychological, and environmental factors. Low socioeconomic status, peer influence, adverse childhood traumatic experience, social isolation, systemic racism, chronic stress. So, let's say a normal person living a happy life would not need to have drugs, right? There are certain underlying conditions like low socioeconomic conditions, stress from the family, adverse childhood, adverse childhood experience that would have, a feeling of guilt, a feeling of unhappiness, uneasiness within oneself, can lead to have the feeling that they need something to make them happy, right? So underlying multifactorial interactions like adverse childhood trauma, isolation, racism, stress, right? Certain comorbid condition may also predispose individual to substance use disorder like mental illness, chronic disease, acute and chronic pain. Very, very common is the pain. The chronic pain is the very common condition that a patient is into the drug use. So we commonly see it in clinical practice that patient coming in with chronic pain are ending up in, substance use disorder. So mental illness, chronic disease, and chronic pain. Now environmental factor play a significant role in exposure to the substance. For instance, the over prescription of opioid for pain in North America played a major role in the development of opioid use disorder crisis. So that's what we were discussing in the previous point as well, that chronic pain is something that is the reason for, like, the prescription of opioid in Canada, that is actually causing to have the dependence. So environmental factors, underlying conditions, and the rewarding system that a drug can bring in. So these are the etiologies. Now coming to the diagnosis, each specific substance is addressed as a separate use disorder, and this diagnosed utilizing the same overarching criteria. A single patient may have moderate alcohol use disorder and a mild stimulant use disorder. Okay, so each substance is addressed separately. Alcohol along with opioid are two different things, so we need to address both of them individually, because the treatment for alcohol would be different and the treatment for stimulant use disorder would be different. So there are two different things in one patient that may appear. Okay, testing for illicit drug is most commonly done on urine and blood samples. So two different samples, urine and blood sample. Serum toxicology screen measure recent alcohol consumption but has no relation to the diagnosis of alcohol use disorder. Serum, a toxicology screen measures the recent alcohol consumption but has no relation. So, for instance, I test a person for alcohol use disorder and I check their serum toxicology and it comes out positive. It doesn't mean that a patient is an alcoholic or using alcohol too much. Why? Because that's something that he might have just taken a while ago. So, serum toxicology is not something that I can rely on to make a diagnosis for alcohol use disorder. Toxicology may be helpful in differentiating withdrawal from other mental disorders. Urine drug screen are useful for detecting recent drug use but not for diagnosing substance use disorder. So there are various things that we've just discussed. So for diagnosis, number one is we need to take two different approaches for two different drug use disorder, and then testing for illicit drug is most commonly done through urine and blood. Serum toxicology screening for alcohol consumption has no relation to the diagnosis of drug used alcohol use disorder, and then toxicology may be helpful in differentiating withdrawal from other mental disorder. Urine drug screen are useful for detecting recent drug use but not for diagnosing substance use, right? Now, substance use disorder are measured on a continuum of mild to moderate based on the number of criteria met. So, they have made a criteria for the substance use disorder. For mild, there would be 2 to 3 criteria. For moderate, 4 to 5 criteria. And if it's more than 6, then that means that is severe substance use disorder within the 12 months, past 12 months. Criteria for substance use disorder, there is a mnemonic that is PEC with MCAT. PEC with MCAT. So use despite physical and psychological problem. P for physical and psychological problem like alcohol, liver disorder, cocaine related nasal problems. Even the patient would have the physical problems associated with the drug use, they'll still continue using the drug. That means they are dependent on it now. They are addicted to it, right? So that is the physical and psychological problem with P, and then E comes with external roles at work and home. So failure to fulfill them, right? If a patient is going to work, patient is going to school, their roles are affected with because of the dependence, craving or strong desire to use substance. So they'll continue to have craving. P is for psychological, E for external roles are affected, C for cravings. Now W for withdrawal. Withdrawal means that if they do not get the drug, they'll have some physical symptoms. They'll become agitated, they'll have all those, behavioral issues because of not getting the drug. Continuous use despite interpersonal problems, they'll have the problems, they'll have the insight of those problems, but still they would not be able to stop the use. So that is interpersonal problems. Tolerance, needing to use more substance to get the same effect. Use in the physical hazardous situation, like they'll be driving and they'll be having the drugs. So this is hazardous situation. More substance use and for longer period than intended. So they continue to use the opioid despite of the doctor telling them that they need to cut down. They continue using it. Unsuccessful attempts to cut down. Activities giving up on due to substances. Excessive time spent on using or finding substances. The PEC with MCAT is the best mnemonic that you can memorize, just to make sure that you know the criteria, and you know if it's more than 6, then a patient is in severe substance use disorder. P for physical psychological, E for external roles are affected, C for cravings, W for withdrawal, I for interpersonal problems, T for tolerance, H for hazardous situation, M for more substance use or for longer period than intended, and then C for cut down, unsuccessful cut down, A for activities is affected, and T for time spent in drug seeking. So this is the criteria for substance use disorder that you use to um, make a diagnosis. And then you need to know that, for mild to moderate, it's mild is 2 to 3, moderate is 4 to 5, and 6 or more is severe. So PEC with MET, psychological, external, cravings, withdrawal, interpersonal, hazardous situation, more substance use, cut down, activities affected, time spent in drug seeking. So this is the mnemonic, okay? Now, now coming to the right side, questions to characterize substance use and the right risk assessment, the water. So these are the questions that you need to ask the patient while he is in the clinic. That that would give you a significant information if the patient is using the drug excessively. So when was the last time you used it? How long can you go without using it? Have you experienced medical or legal consequence of your use? Any previous attempt to cut down or quit, and did you experience any withdrawal symptoms? How has your substance use affected your work, school, and relationship? Are there any triggers that you know will cause you to use? Substance can be very expensive. How do you support your drug use? By what route, oral ingestion, inhalation, smoking, IV, do you usually use? So these are the water is a mnemonic for this questionnaire. So you can ask these questions in the clinic with the patient, assessing about their substance use. Um, Disorder. And as far as QE1 is concerned, so you may have such questions in the CDM part or even MCQs that they may ask you, what would you ask the patient? Yeah, how would you assess the patient if he is in the substance use disorder? So these are the questions you just need to know a superficial idea, like what are the questions you're going to ask them. If you do not get it, how would you feel? Have you tried quitting it? Have you ever had any legal problems associated with? For how long have you been using it? How frequently are you using? So just imagine, like, if there is a patient in the clinic about this concern, so what questions you're going to ask. So logically, these are the questions that would definitely come to your mind while you are practicing. So that's about it. Then coming to the symptomology. So they're telling you there are three different types of substance, like CNS depressants. One are stimulants and one are hallucinogens. So for depressants, as the name suggests, they would cause your um, physical symptoms related to low mood, low, everything going low, right? Let's say symptoms of intoxication would be euphoria, slurred speech, disinhibition, confusion, poor coordination, coma. Coma is severe. So coma is a low, something making you low. Poor coordination, something making your movements low. Confusion, you're not really sure about your thinking process. Speech slurred, that means you're not able to speak properly. Disinhibition, you're not interested in the things that you used to enjoy. Euphoria is you're happy, right? It would make you feel happy. So for any drug that would make you feel happy, we did study that the underlying pathophysiology is that it increases dopamine, makes your uh, brain activate those rewarding pathways, right? So that's why a patient on drugs would be euphoric, right? Now, what drugs are there that may cause you to have a CNS depression? That is alcohol, opioid, barbiturates, benzodiazepine, and GHB, a type of drug. Okay, so these are the five drugs that may cause you to have CNS depression. Now, what happens if you do not get these drugs? Opposite to what you were having, the effect that you were getting with these drugs. So, anxiety, you're not really happy, you get anxious. Anhedonia, lack of interest. Tremors, you're really not comfortable, right? Seizures, insomnia, psychosis, delirium, and death. So, excessive worrying, excessive tremors, body movements, not able to sleep, psychosis, delirium, death, withdrawal. These are the symptoms of withdrawal. So, if you get intoxicated, you'll get at ease, coma, confusion, slurred speech, disinhibition, poor coordination, euphoria. But if you do not get it, if you get withdrawal symptoms with it, that is, you'll be anxious, you'll not be happy, right? You'll be anhedonic, you do not want to do anything. You're tremorous, you're not relaxed, right? Seizures, excessive abnormal movement of the body. Insomnia, you're unable to sleep. Psychosis, delirium, death, right? So these are the withdrawal associated with CNS depressants. Now coming to the stimulants. Stimulants are something that makes you high, right? Something that makes you happy, euphoric. Let's see. So symptoms of intoxication with stimulants would be euphoria, mania, psychomotor agitation, anxiety, psychosis, paranoia, insomnia, cardiovascular complications, stroke, MI, arrhythmias, and seizures. So these are intoxications with stimulants because they are stimulating you. That's why you're becoming psychotic, you're becoming anxious, you're becoming manic, you're becoming agitated, insomniac, seizures. These are all associated with stimulants. Now, what are the substances? These are amphetamine, methylphenidate, MDMA, and cocaine. So, amphetamine is something that you give for ADHD, methylphenidate, MDMA, and cocaine. Okay, so these are the things that are stimulants: amphetamine, methylphenidate, MDMA, and cocaine. Four substances are stimulant, and the other five are depressants. What other five are depressants? Alcohol, opioid, barbiturates, benzodiazepines, and GHB. What happens? What happens if you do not get the withdrawal? What happens if you do not get the stimulants? What withdrawal symptoms do you get? These are cravings, crash, craving, dysphoria, and suicidality. So that is extreme because when you were getting stimulated and you felt good, but now you do not get those feelings, and now you would just wanna, have it, and you would kill yourself in case you do not get it because it has made you so high that it's not, it's not helping your brain to work now. It's not even making your brain to work. So you can harm yourself, you can crave for it, dysphoria, and crash. So this is something very, very serious now. How about hallucinogens? Hallucinogens are LSD, mescaline, psilocybin, PCP, ketamine, ibogaine, and salvia. Symptoms of intoxication: distortion of sensory stimuli and enhancement of feeling, psychosis, visual hallucinations, delirium, anxiety, panic, and poor coordination. So the feelings, the psychosis, visual hallucinogens would cause you to have hallucinations, poor coordinations, and not within yourself, right? Distortion of sensory stimuli, enhancement of feeling, psychosis, visual hallucinations, anxiety, and poor coordination. If you do not get hallucinogens, what withdrawal symptoms you will have? Usually absent, nothing. You wouldn't have anything, right? So that's how the substance symptomology is. So they're divided into stimulant, depressant, and hallucinogens. Okay, so hallucinogens are basically something that would cause you to see things or hear things that others are not um, seeing or listening, right? So that's what we have covered so far. Now the general approach to assessment. Let's say a patient is there with substance use disorder. How would you approach the patient now? A comprehensive evaluation should inquire about drug history, including the names of the substance you're using, amount, how frequently are you using, how much are you taking, the amount, duration, for how long have you been using it, routes, what routes you have been using, oral, IV, or what. Last use, when did you last use the drug? And injection drug use, are you sharing the needles? Are you using injections? Yes. And if you're sharing them, symptoms of withdrawal if you do not get the drug. These are the similar questions that we read up in the water questionnaire, right? And now the consequence of the use, like medical, social, or personal, like you have you ever been in a legal problem, previous treatment programs, medical, like HIV, hepatitis B, C, or chronic pain, what medical conditions you have that I should know about, psychiatric, mood and anxiety disorder, social history, like family, housing arrangements, and any child safety concerns. Like we read before, that any patient who is in a mental disorder, a 50% chance of getting into substance use disorder. But what mental problems? We read that 50% in patients with schizophrenia, approximately 20% patients with anxiety, right? So we need to rule out underlying anxiety or mood disorders, just to rule out if there's any medical condition that we need to treat along the side of you treating the substance use disorder. So ask about more socially accepted substances like nicotine and alcohol. You need to ask first about those drugs that the patient is currently taking, and then you need to dig into the further history of socially acceptable drugs like nicotine and alcohol before asking about the use of cannabis, misuse of prescription medicines, and about illicit drugs. So let me share a general approach on how we talk to patients in clinic. Is that how I usually do is like in the social aspect of the history. I usually go like, do you smoke? I go with the less a less additive to more additive stuff. Let's say I speak about smoking first because that is more socially accepted, right? And then I go to alcohol, and then in the last I do ask about recreational drug use, and I ask it very carefully, because you don't know. You need to give signpost. You have to do signposting before you're speaking to a patient about the substance use, because this is something that is very personal. A patient might not even like you asking such questions, even if they're taking it, right? So be very careful about your questions, the way you're asking them. So that's what they're telling here. So ask about more socially accepted substance than before asking about the substance use. And then obtain a collateral history is recommended, as well evaluating patient insight into the problem. So you need to ask about the patient themselves, that what do they feel? Are they even thinking that it's a problem for them? Are they willing to quit? What are their thoughts? And in case there is some partner with them, or there's some friend, or there's anyone in the family who's there with with the patient in the clinic, make sure to obtain the history from them as well. Let's say a parent is there, or a partner, a wife or a husband. So make sure to ask collateral history from them. So that's how the general approach is: asking the question specific to the drug, asking about the more socially accepted drug, and then the collateral history. Okay. Now lab testing wise, urine, saliva, sweat, here. Four things that can be tested for the presence of drug: hair, sweat, saliva, and urine. Urine is the most commonly used due to ease of collection and adequate sensitivity, specificity, but it does not reflect the serum concentration. Proper urine drugs testing involves an initial screening test, qualitative, followed by confirmatory testing for substance use with positive screening results. So, urine is most common one, but it does not specifically tell the serum concentration. And the proper urine drug screen testing involves the initial qualitative, followed by confirmation with the positive screening results. Most confirmatory tests uses gas or high perform liquid chromatography. Mm, okay, gas and liquid chromatography. Yes, post ingestion window of detection with urine test amphetamines is 48 hours. Let's say a patient has taken amphetamine, and that would come in urine for 48 hours. After 48 hours, barbiturate would come in 1 to 21 days. They would be there in the urine. And for short acting benzodiazepine would be there for 72 hours. Long acting benzodiazepine for 30 days, cocaine for 12 to 72 hours, morphine for 48 to 72 hours, methadone for 72 hours, oxycodone for 2 to 4 days, PCP for 8 days, cannabis for 3 days for single use to more than 30 days for heavy use. So let me help you with how to remember it. So a general approach is, what I see is 72 hours. That makes it around 3 days. So for benzodiazepine, morphine, cocaine, this is for 3 days. But like, let's say which one is the one that stays in longer in the blood or in the urine is cannabis. That is for more than 30 days. And 30 days is cannabis, and long acting benzodiazepine is also staying in urine for 30 days. So that's how you need to remember. The approximately it's for 72 hours, that is 3 days. But for cannabis and long acting benzodiazepine, it's for 30 days. Okay. Limitation: negative tests cannot rule out substance use, and positive tests cannot determine how much or frequent use. So, general approach to the treatment is: approach must be appropriate to the patient's current change of status. So, we'll be looking into public health promotion strategies, pH 11 section for that approach. And then, patient will change when the pain of change appear less, and the pain of staying the same. Patient will change when the pain of change appear less and the pain of staying the same. Providers can help by providing psychoeducation, emphasize neurobiological model of addiction, motivation, and hope. Principle of motivation interview is non-judgmental stance. We need not to be very judgmental about. We need not to be actually judgmental about the statement that we are asking. Space of patient to talk. Let them talk. Let them speak. Offer an accurate empathic reflection back to the patient to help frame issues. So how do I do it? I know, I understand that this must be really frustrating. I understand this must be really difficult, but this is doable. And let them know that the situation that they're going through is very common. That's how you do it, right? And encourage and offer referral to evidence-based services. Encourage and offer referral to evidence-based services. What are the evidence-based services? Social 12-step programs, Alcohol Anonymous, Narcotic Anonymous, Family Education and Support, Psychological Therapy, Addiction Counseling, MET, CBT, Contingency Management, Group Therapies, Family Therapies, Marital Counseling. Medical management. So first is the social aspect, very important. These two things that we just read are very important for QE1 aspect, that you need to remember the evidence-based services that are available in town to help the patient about the addiction problem. Let's say 12-step programs, Alcohol Anonymous, Narcotic Anonymous, psychological therapy, psychosocial aspect of the patient that needs to be addressed, like CBTs, marital counseling, family therapies, addiction counseling. These are the things that you need to remember for CDM aspect of QE1. Even for CDM and even for QE1, they generally would like to ask more about these things. Medical management differs depending on the substance. So, acute detoxification pharmacological agents to aid maintenance. Ontario has the RAM, Rapid Access to Addiction Medicine Clinic, that offers timely, low barrier, specialized service by self referral. So, RAM is one of the most famous services available in Ontario region that helps the patient with the addiction services. If you write RAM in your exam, that would something be very high yield, or something that would actually stand you out from other candidates, right? Then harm reduction whenever possible, safe sexual practices, avoid driving while intoxicated, avoid substance use with child care, safe needle practices, exchange pill testing kits, and reducing tobacco use. Harm reduction is second most important thing after the psychosocial support that you're giving to the patient. Then harm reduction means if a patient continue using drugs, you need to let the patient know about the safe sexual practices, avoiding them to have STIs, avoiding them to have HIV, hepatitis B, and then safe sexual practice is another thing. And then safe avoid driving while intoxicated, you need not to drive. Then safe substance avoiding substance while with the child care, a household with a child needs to be very careful about their drug use. Safe needle practices, avoiding the transmission of infection. Pill testing kits, so make sure that they have the naloxone kits or another stuff like that, just to avoid them getting into the respiratory depression. And then reducing the tobacco use along with the drug use. So these are a few of the harm reductions that you need to memorize. Then comorbid psychiatric conditions, many will resolve with successful treatment of substance use. Comorbid conditions would be resolved with substance use, but patients who meet full criteria for another disorder should be treated for disorder with psychological and pharmacological therapy. Let's say a patient is an anxiety disorder, a depression disorder, along with substance use. We need to treat them separately for both of them, because these are two different conditions. Always consider duty to inform the Ministry of Transportation for risk of driving and operating other vehicles. So, one of the most important aspect, another important aspect of QE1 is that you need to remember that when are you supposed to report the patient to public health, the patient to Ministry of Transportation, the family to child protective services. So these are the three most important reporting services that our doctor needs to keep them in their mind, just for the sake that patient is here and you need to report that to XYZ agencies, right? So we have covered so far. I would just like, go through the aspect that we have covered so far. We have the drugs coming in like nicotine, alcohol now, but I think we'll be covering them in part two of this video. And until then, you just need to remember that we have covered. We're covering one of the objectives of QE1. So this was the overview. We have done the epidemiology. We have done the causes. Why does a patient ends up in substance use disorder? And then we have done the diagnosis. Back with MCAT is an important mnemonic that you need to remember. The questions that you're supposed to know. And then which drugs are suppressants, which drugs are stimulants and hallucinogens. And then the general approach. General approach like seeking history from the patient, seeking history associated with other socially accepted substance, seeking history from the family members, and the collateral history. Lab testing, and then the general approach. The general approach, the important aspect of general approach is that you need to remember that motivational interviewing skills, number one. Number two is the psychosocial aspect that we need to address, 12-step program, Alcohol Anonymous, Narcotic Anonymous. Then CBT is something very important. Medical management is very specific to what the patient is taking. And then harm reduction policies, like needle sharing, avoiding needle sharing, safe sexual practices, avoid driving while intoxicated, child care, safe sexual practices, pill testing, reducing tobacco. And then um, the other one, most important one, was the reporting. Consider duty to inform the Ministry of Transportation about the risk of the driving, okay, and operating other vehicles. So that's about it for this video. And then in the next video, I'm gonna cover alcohol, uh, opioid, cocaine, and amphetamines, cannabis, hallucinogens, whatever drugs we have in here. Okay, so stay tuned. Make sure you watch another video just to complete this objective. This is the lengthy objectives that would be covered in two videos. So one video is this. The next video you can continue watching. Thank you so much.